Hi and welcome back to another video of Medic Notes. This video is on rectal prolapse. A rectal prolapse is the protrusion of mucosal or full-thickness layer of rectal tissue out of the anus. There are two main types of rectal prolapse. Full thickness, where the rectal wall protrudes out the anus, and partial thickness, where only the rectal mucosa protrudes out of the anus. For full prolapse, theories suggest that is a form of sliding hernia, through a defect of the fascia of the pelvic region. This may be caused by chronic straining secondary to constipation, a chronic cough, or from multiple vaginal deliveries. In contrast, partial thickness prolapses are associated with the loosening and stretching of the connective tissue that attaches the rectal mucosa to the remainder of the rectal wall. This often occurs in conjunction with long-standing hemorrhoidal disease. The main risk factors for rectal prolapse are increasing age, female gender, multiple deliveries, straining, anorexia, and previous traumatic vaginal delivery. For clinical features, patients with a rectal prolapse will typically present with rectal mucus discharge, fecal incontinence, per rectum bleeding, or with visible ulceration. Full-thickness prolapses will begin internally, and thus can initially present with a sensation of rectal fullness, tenesmus, or repeated defecation. On examination, the prolapse may not always be evident, but can be identified by asking the patient to strain. A digital rectal examination should be performed. Expected finding is a weakened anal sphincter. For a suspected internal prolapse, defecating proctography and examination under anesthesia may be the only means to diagnose clinically. This is a diagram showing a full-thickness rectal prolapse. Conservative management of rectal prolapse is more common in those unfit for surgery, with minimal symptoms, or in children. As most prolapses in children will resolve spontaneously. Initial management involves increasing dietary fiber and fluid intake. Minor mucosal prolapses may be banded in clinic, but the recurrence rate is high. Surgical repair is the only definitive management. The mainstay of treatments is between the abdominal approach and the perineal approach. In perineal approach, the two more commonly performed operations are the Delorme's operation, where the prolapsed lining of the rectal mucosa is removed and the underlying muscle reinforced with plicated sutures. Another operation is the Altemeyer's operation, where resection of the redundant prolapsed bowel to restore the original anatomy is done. The other approach is the abdominal approach. This is performed laparoscopically, robotically, or open. The procedure will involve a rectopexy, whereby the rectum is mobilized and fixed onto the sacral prominence via sutures or mesh. That's all for this video. Thank you.